The Subcommittee for Indigenous Peoples of the United States will now come to order. Good afternoon and welcome to the first hearing of the Subcommittee for Indigenous Peoples of the United States in the 117th Congress. Before we begin, I must acknowledge the grief and despair in Boulder as we mourn yet another shooting, this time in several of our communities, colleagues in the state of Colorado, and we continue to grieve the lives of those lost in Atlanta last week. Know that all of us in New Mexico and in this subcommittees, our hearts break with yours and our blessings flow to your committees. The subcommittee is meeting today to hear testimony on a year in review, the state of COVID-19 in Alaska, Native and Native Hawaiian communities, lessons learned for future action. Under Committee Rule 4F, any oral opening statements at hearings are limited to the chair and the ranking minority member. This will allow us to hear from our witnesses sooner and help members keep to their schedules. Therefore, I ask unanimous consent that all of the members' opening statements be made part of the hearing record if they are submitted to the clerk by 5 p.m. today or the close of hearing, whichever comes first. Hearing no objections, so ordered. Without objection, the chair may also declare a recess subject to the call of the chair. Hearing no objection, so ordered. As described in the hearing notice, statements, documents, or motions must be submitted to the electronic depository by 5 p.m. today or at the close of the hearing. As described in the hearing notice, statements, documents, or motions must be submitted to the electronic depository HNRC docs at mail.house.gov. Additionally, please note that as with in-person meetings, members are responsible for their own microphones. Finally, members or witnesses experiencing technical problems should inform committee staff immediately. I will begin by recognizing myself for an opening statement. I want to thank each of our witnesses for sharing their knowledge and insight for this subcommittee's first hearing. As the new chair of the subcommittee, I must acknowledge all of my colleagues who've championed Native American, Alaskan, and Native Hawaiian issues for so long, for so many years in Congress. I especially acknowledge Chair Grijalva and our Dean of the House, Ranking Member Young, as well as my immediate predecessor, Congressman Gallego. With the historic elevation of our former colleague and my fierce New Mexican hermana, Secretary Deb Haaland, this subcommittee also stands at the cusp of history. Secretary Haaland understands issues affecting Indigenous people as no one else before her could. With the Secretary of the Interior who so intimately understands both the trust responsibility and, sadly, the centuries of neglect, we have the opportunity to effect the long-lasting change that communities within the jurisdiction of this committee have been asking for. Imagine if the history books mark this period as the true transition to economic and cultural sovereignty for our communities. I envision a productive congressional session where we work collaboratively with the department and our Indigenous communities and governments to address many of the structural issues that have caused the great sorrow and despair that we will hear about today. I am honored to serve this subcommittee as it advocates for the 2 million Indigenous peoples of this country. I was counsel to numerous Native American tribes and their entities for 30 years. Indeed, I attended my first tribal council meeting at Secretary Haaland's Laguna Pueblo in 1990 and my last on December 18, 2020. While I have brought the legal expertise to the team, I was also taught to see the different perspectives and to honor the Indigenous wisdom. I was lucky enough to work with my tribal mentors on many groundbreaking projects, from building health clinics and infrastructure to promoting economic development and protecting everything in between. Self-determination and tribal sovereignty were the very principles upon which my daily work depended. Today's hearing will highlight the structural deficiencies that led to the devastating impact of COVID-19 on Native American and Indigenous communities. A year into the pandemic, American Indian and Alaska Native populations continue to have the highest COVID-19 infection, hospitalization, and death rates in the country. Native American Hawaiians represent the third highest pool of COVID-19 positive patients in the state of Hawaii. A review of this sad year is essential for us to begin to comprehend the underlying vulnerabilities that cause such deadly despair. The hearing subtitle calls us into action. Our call to action in the 117th Congress must recognize that Indigenous peoples have demonstrated an incredible resilience over generations. What we will hear from our experts today and ask leaders throughout our Native American, Alaska Native, and Native Hawaiian communities is, what can Congress do to help you build upon that resiliency so that your communities are strong enough to handle both future pandemics and the current economic and climate crisis we face? I've asked the witnesses to take some of their time to direct our attention to specific policies they'd recommend to build that future resiliency and to help us learn the stories of what does it need to be, what do we need to do differently. And for example, when we talk about like there's overcrowding in our in our housing and that led to COVID, let's not think that it's wrong to have multi-generational families living together, only that it's wrong if they are forced to live in conditions where they don't have running water. And if multi-generational housing is the choice, what can we do to make that happen, like they did in OK Oringe? So I want us to be open to those kinds of views. I also want us to think about the manner in which we will need to, in the future, address additional crises that this committee must look at. We must look at how do we create economic sovereignty? How do we do economic development? And as we go and think about the climate crisis and its impact on our Indigenous, Native American, Hawaiian communities, let's take to heart the testimony we will hear today about incorporating Indigenous wisdom as we combat climate change. I also know that we will be looking and need to look at cultural preservation. We will need to look at the government to government relationship and how do we build in that relationship a true partnership, because it's only when we work in true partnership with our members that we will be able to address the issues. I would now like to recognize for statement Don Young, our Dean of the House. He is with us by phone today. Dean Young, Congressman Young.
Can you hear me?
Yes.
Can you hear me?
Yes, we can.
You can hear me?
Yes, we can.
All right. Thank you, Madam Chair. Thanks for holding this hearing. Thanks to the witnesses. I would like to repeat much of what you said. In the case that I've been working with the Aboriginal people, my first Americans for as long as I've been in Alaska, 65 years. And what I'd like to have you, as a chairman, recognize that a lot of time we talk and we don't walk too well. And I've been around for this, and we talk about self-government, and we don't really allow to have self-government in many areas. Self-determination, same thing. And I just like to see the Aboriginal people in my state and other states to rise to the levels I believe they can, have done in many areas, done an outstanding job. As far as the pandemic goes, we've done well in Alaska. We could do better. I think we ought to look at the potential for another epidemic of some type where my people are scattered all over 229 tribes, that they have a plan. We set up a plan to the trust relationship that if an attack, we can respond much quicker than we did. We ended up doing a fair job. We could do a better job. We have challenges up there, as everybody knows, because of the distances, and we will look into it. I've been very supportive of the Hawaiian Native. Mr. Case, you know that all these years. We make sure that you're included in anything we try to do for Hawaii and the natives of Hawaii, and of course all the First Americans in the lower 48. I like to make sure that if we write legislation, that we're all included. We've had a short recent situation where some lower 48 tribes took a shot at my native tribes, and I don't like it when tribes start fighting amongst themselves. I want them to work together as a unit, and we can pass a law that makes sure everybody is recognized equally, and we can achieve those goals as far as healthcare, housing, running water, etc. On the running water aspect, that we have probably the bigger challenge, in the sense we have put a lot of money into running water and drinking portable water and sewage. And unfortunately, we don't provide the money to maintain the equipment. And a lot of it's been actually been non-functioning because of that. So anything we do, we have to make sure if we are part of the trust relation and we do distribute monies for those type of situations, we include monies for the operation. So again, Madam Chair, I will be listening. I'm in a car, and I'll be trying to communicate. Again, thank my witnesses, and I hope when they testify that they follow through with solutions. A lot of times those on the ground get better solutions than we do in Congress because they actually experience it more. That's the big job. I know knowledge is power, and more knowledge this committee will get, we will be able to achieve a great deal. And again, Madam Chair, I look forward to working with you. You'll find me very bipartisan in the sense that I want to have really working relationships to get things done for the first peoples of America. I'll continue to do that. You've always had my support. I'll continue to work on things that affect those people adversely and try to improve their lives. And with those few words, I yield back, Madam Chair.
Thank you so much for those words. I now would like to recognize that we do have the chairman of the full committee, Chairman Raul Grijalva. I do not know that he wants to have any statement. Chairman, would you like to make a statement?
No, other than to thank you, Madam Chair, for hosting the hearing, and to the ranking member and the witnesses for being here, and I look forward to their testimony. Thank you, and I yield back.
Thank you so much. I would now like to turn it over to hear remarks of the ranking chair of the subcommittee, Mr. Westerman.
Thank you, Madam Chair, and our Dean of the House, Ranking Member Young. Glad to be part of the hearing today and welcome our witnesses. And I know I see Ms. Radawagin on. I'm not sure if she's in American Samoa, but I know I was on a hearing earlier with Mr. Sablan, and I think it's now like 3 a.m. in Saipan, and tomorrow and today in American Samoa. So it's great to have everybody together here. And as everyone can attest, the COVID-19 pandemic has had a severe impact not only on our nation, but on our American Indian and Alaska Native communities who have experienced the brunt of the pandemic's effects. American Indian and Alaska Native populations have and continue to experience disproportionate levels of underlying health conditions like diabetes and chronic obstructive pulmonary disease. Many of these conditions are listed by the CDC as major contributors that lead to a higher risk for contracting COVID-19. This is added to the reality that many tribal communities lack proper water delivery systems, sanitation facilities, and other disparities, which create a perfect storm. And as Ranking Member Young mentioned, not only is it important to get these systems, but to be able to operate and continue maintaining them. As a result, several tribal communities continue to experience higher cumulative % positive COVID levels than the rest of the country. Cases in the Navajo region continue to be twice the national average. This is just, quite frankly, unacceptable in 21st century America. I'm thankful that we were able to develop a vaccine in 7 months, provided vaccine development usually takes anywhere from 5 to 10 years. The Operation Warp Speed initiative announced under the previous administration was a monumental success and will save thousands of lives. As of March 22nd, 2021, 850,228 vaccine doses have been administered in the 12 IHS regions. While this is good news and more people are vaccinated every day, more must be done to ensure that more American Indians and Alaska Natives receive these vaccines as soon as possible. Congress has also provided more than $9 billion to the IHS specifically to respond to the COVID-19 pandemic, which is in addition to the $6.2 billion from fiscal year 2021 appropriations. Added together with funding provided to other agencies, more than $35 billion has been appropriated through the CARES Act and the American Rescue Plan Act in response to COVID-19 in Indian country. While additional funding for Indian health and economic relief is certainly supported in this time of need, we will need to work together to find other common sense solutions, as this level of funding will not be sustainable in the long run. I hope to work across the aisle to ensure these funds are spent efficiently and effectively and find other pragmatic solutions to address the needs in tribal communities. Needs are different for each of the 575 federally recognized tribes, and there must be transparency and accountability. I look forward to today's conversation and thank our witnesses again for their participation. And Madam Chair, I yield back.
Thank you so much for those opening comments. And now we will turn to our witnesses. And first, I want to say it again. I don't think we can say it enough, to give gratitude to the witnesses for sharing their insights with the committee. I also must remind the witnesses that we've received and reviewed your written statements, and under our committee rules, oral statements are limited to 5 minutes. So we encourage you to highlight issues you'd like to discuss in those 5 minutes. You may also submit an additional statement for the record after the hearing. When you begin, the on-screen timer will begin counting down and will turn orange when you have 1 minute remaining. I recommend that if you haven't done it, that members and witnesses remotely lock the timer on their screen. We'll seek to limit statements and questions to the 5 minutes so as to be respectful to the other witnesses and allow time for each member to ask questions. After your testimony is complete, please remember to mute yourself to avoid any inadvertent background noise. I will allow the entire panel to testify before we question the witnesses. The chair now recognizes the Honorable Carmen Lindsey, who is the chair for the Office of Hawaiian Affairs.
Aloha, Subcommittee Chair Fernandez, Subcommittee Ranking Member Young, Committee Chair Grijalva, Committee Ranking Member Westerman, and the members of the House Subcommittee for Indigenous Peoples of the United States. My name is Carmen Lindsey, and I am the chair of the Board of Trustees for the Office of Hawaiian Affairs. Thank you for inviting me to provide testimony and to respond to questions on behalf of OHA and the Native Hawaiian community. I extend a warm aloha to Congressman Case. OHA is a semi-autonomous agency of the state of Hawaii, whose mission is to better the conditions of Native Hawaiians. My written testimony chronicles the disparities Native Hawaiians face in health and welfare, in violence against women and children, in the criminal justice system, and in dealing with the effects of climate change. I will focus on the effects of COVID-19 on missing and murdered Indigenous women, and on incarcerated Native Hawaiians. Native Hawaiians face disproportionate sexual violence and trafficking. A recent study found that 64% of trafficking victims in Hawaii identify as Native Hawaiian. Native Hawaiians are more likely to face intimate partner violence than non-Hawaiians. Native Hawaiian children are disproportionately affected by sexual exploitation, including sex trafficking. COVID-19 adds financial stress, unemployment, isolation, increased family conflict, and deepening mental health issues to those volatile situations. Lockdowns and COVID restrictions force survivors to spend more time with abusers, less time with support networks, and leave few options to escape. I urge this subcommittee to include Native Hawaiians in efforts to address the missing and murdered Indigenous women crisis and to end violence against Native women and children. Mahalo, Congressman Case, for your amendment addressing these issues. Native Hawaiians are disparately impacted at every stage of the criminal justice system, from arrest through parole. The medium security Saguaro Correctional Center in Eloy, Arizona, houses more than 1,000 inmates from Hawaii. A National Indigenous Women's Resource Center article reported that 48% of the prisoners in Saguaro are Native Hawaiian. While Hawaii's latest unofficial count of self-identified Native Hawaiians at Saguaro is 37%, anecdotal reports OHA received from advocates and inmates at the center estimate the Native Hawaiian population as much higher. During the pandemic, COVID outbreaks at Saguaro resulted in over half of the inmates from Hawaii testing positive. Hawaii facilities have reported significant outbreaks too. This increased exposure endangered Native Hawaiians already at risk for COVID complications due to pre-existing health conditions. Inconsistent reports of the number of Native Hawaiians housed out of state underscore the importance of Congressman Case's amendment requiring the Attorney General to collect and accurately report Native Hawaiian criminal justice data. Mahalo again, Congressman Case, for your leadership. Further, Native Hawaiians did not traditionally have prisons designed for punishment. Instead, we had pu'uhonua, places for healing. OHA supports programs where Native values and healing traditions are integrated into rehabilitation programs. We urge this committee to support reentry programs that provide wrap-around support and services beginning prior to release and continuing through integration. My message is simply this: Congress must honor its trust responsibility to American Indians, Alaska Natives, and Native Hawaiians. It is time Native Hawaiians are included in federal policies, in federal reports, and in discussions like these today. Mahalo for allowing me the opportunity to provide remarks. I am happy to answer any questions from members of the subcommittee. Aloha.
Aloha, and thank you very much, Chairman Lindsey. I understand that you may need to leave early and that if there are additional questions that come from the committee after you leave, that they may submit them in writing and you will provide us your answers. The chair now recognizes the Honorable Rodney Costan. The chair now recognizes the Honorable Rodney Costan, who is the chairman for the Confederate Tribes of the Colville Reservation's Business Council.
White Fescal Halt, Tatsalach, in West Winik Tipyalachna Tsitskin. Good afternoon, Chairwoman Fernandez, Ranking Member Young, Ranking Member Obernolt, and members of the committee. My name is Rodney Costan. I am the chairman of the Colville Business Council, the governing body of the Colville Tribes. The Colville Tribes is a confederation of 12 Aboriginal tribes and bands from across eastern Washington, northeastern Oregon, Idaho, and British Columbia. The Colville Reservation covers approximately 1.4 million acres, making us one of the largest Indian tribes in the Pacific Northwest and the second largest in the state of Washington. And the size of our reservation and the landscape of the reservation is actually one of the largest or the greatest challenges that we had to face during the COVID pandemic, well, which is still ongoing. 922,000 acres of our reservation land base is timber, and forest management is something that the Colville tribe takes very seriously. Working with IHS to help control the spread of the virus. Colville is a direct service tribe. Early in the pandemic, the Colville tribes worked with the Colville Service Unit on strategic planning to control the spread of the virus. The Colville Service Unit provides health care to 2,978 patients with underlying health conditions that make them especially vulnerable to COVID-19. This is a third of all of our active patients. Despite personnel challenges and the lack of public transportation infrastructure, the combined efforts of IHS and the Colville tribes has led to the vaccination of 40% of this vulnerable population. We consider our work with IHS to be a success story. COVID-19 has underscored the Colville tribe's health facilities needs and impacted our ability to address those needs. In May 2020, the IHS announced that the Colville tribe's clinic in Omak, Washington, was one of 5 projects it selected for the joint venture facility construction program out of 34 total applicants. Having applied twice since 2010, the Colville tribe was extremely grateful to finally be one of those selected. Under the joint venture program, an applicant agrees to construct and in most cases equip a health facility in exchange for IHS paying for a portion of the reoccurring staffing costs. COVID-19 has reduced tribal healthcare revenue and has threatened the viability of the Colville tribe's business plan to construct the Omak clinic. Because of the pandemic's impact on our project, we have asked IHS to use leased to use some of the money that Congress recently appropriated to it to assist those joint venture projects that have been impacted by the pandemic, including our OMAC clinic project. The pandemic highlighted longstanding needs for more forest management and broadband resources. Since 2015, the Colville Tribes has endured two major wildfire events that have collectively resulted in 537,000 acres being burned and approximately 1 billion board feet of timber lost. In 2015, the North Star and Okanagan Complex fires collectively burned more than 255,000 acres on the Colville Reservation, nearly 20% of the total land base. In the midst of the COVID-19 pandemic last September, the Cold Springs and Inchelium Complex fires burned 200,000 more acres and tragically resulted in an infant death. In addition to the fatality, these fires resulted in the on-reservation loss of 78 homes, 138 other structures, and destroyed 161 miles of rangeland fence and hundreds of head of cattle. Smoke from the fires aggravated respiratory problems from vulnerable tribal members and those infected with COVID-19. The fire underscores the Colville Tribe's longstanding need for additional fuels reduction and tribal forestry dollars from the Bureau of Indian Affairs to enable us to move our forest landscapes closer to the historic conditions. The wildland fires also highlight the need for lack of communications infrastructure for rural tribes like the Colville Tribes, both for emergency management and distance learning. This concludes my testimony, and I'd be happy to answer any questions that the committee may have.
Thank you so much for your testimony. And now the chair will recognize the Honorable William Smith, who is the chairperson and Alaska Area Representative for the National Indian Health Board. Mr. Smith. Chair Smith.
Congresswoman Leger Fernandez, Ranking Member Young, and members of the subcommittee, on behalf of the National Indian Health Board and 574 sovereign federally recognized American Indian and Alaska Native nations we serve, thank you for this opportunity to be a witness and provide this testimony. 1 year later, our nation still faces the COVID-19 pandemic, and it continues to disproportionately ravage our people. For centuries, U.S. policies around American Indians and Alaska Natives have been stained by broken treaty promises, chronic underfunding, boarding schools, and so much more. These stains, failed policies, and neglect have brought the same results to tribal communities on earlier pandemics. That is a great loss and a heavy burden. The CDC reported that the presence of COVID health conditions such as type 2 diabetes, obesity, and health disease dramatically increases one risk for COVID-19 illness. Our people are painfully impacted on each of these chronic health conditions. As of March 20th, the Indian Health Service reported over 189,000 positive COVID cases. That number is understated because reporting by tribal operated health programs, which is about 2/3 of the Indian health system, report data voluntarily or on different electronic health records systems. According to the CDC, our people are 1.7 times more likely to be diagnosed with COVID-19 when compared to non-Hispanic white people. The CDC, we are 3.7 times more likely than non-Hispanic white people to be hospitalized with severe COVID symptoms, and 2.4 times more likely to die from COVID-19 infections. In my home state of Alaska, 37% of the state deaths are reported to be natives. There are nearly 6,000 American Indians and Alaska Native deaths reported related to COVID-19 complications since the pandemic was declared. And that's a number that is likely understated. Nearly 60% of these deaths are from New Mexico, Arizona, and Oklahoma combined. The key success was including tribal Indian Health Service as a jurisdiction. As of March 22, there has been 1.36 million vaccines distributed through the IHS, and over 850,000 doses have been put into arms. For instance, a key to Alaska's success in vaccinating against COVID-19 is steeped in the tribes having sovereign ability to self-determine and exercise flexibility. Some of our tribal communities in Alaska have reached 90% vaccine rates among the seniors and included natives and non-native residents. Various tribes in Oklahoma have also opened up their vaccine efforts to the communities. Regardless if there are Indian Health Service eligible. Federal data shows Native Americans were given vaccines at a higher rate than all of the 5 states by the end of February 21. HR 1319, the American Rescue Plan, provides unpredictable investments into Indian country and Indian health, with over $6 billion being injected into the Indian health, tribal, and urban system. We are encouraged to witness this funding effects and the improvement that it will make in care, facility, and lives. National Indian Health Board is grateful for these investments and thankful for those in Congress who supports the inclusion of these funds. While American Rescue Plan provides much needed support to Indian country, ongoing request and pandemic is far from over and there is much work still left to be done. We call on Congress to provide full funding and mandatory appropriations for the Indian Health Service. It is the most chronic, underfunded federally healthcare system and the only federally healthcare system not exempt from government shutdown and continuous resolution. Congress must further prioritize tribal water and sanitation infrastructure. Approximately 6% of the tribal households lacks the running water. When asked to wash their hands to keep them safe from COVID-19, some tribal members are unable to do so for the lack of clean running water. Additionally, there must be continued support for tribal mental and behavioral health, access to broadband in tribal lands, creating an unsustainable tribal health workforce, and expand tribal self-governments across the entire federal government. To close, consider this: during both the Spanish flu pandemic and the 2009 H1N1 pandemic, Native people died at 4 times the rate of all other races. We were left to fend for ourselves and die. The federal government needs to do better at this moment and in the future. I am grateful for the members of the subcommittee and your actions to support Indian country. I urge you to further prioritize tribal and tribes communities as they continue to provide relief to the COVID-19 pandemic and beyond. Please remain with us to enhance the ITU system and ensure that it never happens to Native people again. Thank you, Awata, for holding today's hearing and for inviting National Indian Health Board to testify. I am looking forward to your questions.
Thank you for your testimony today. And the chair now recognizes Ms. Francis Crevier, who is the Chief Executive Officer for the National Council of Urban Indian Health. Ms. Crevier.
Thank you. Hi, my name is Francis Crevier, and I'm Algonquin and the CEO for the National Council of Urban Indian Health. On behalf of NCUI and the urban Indian organizations we represent, I would like to thank Chair Leger Fernandez, Ranking Member Young, and the members of the subcommittee for the opportunity to testify today. UIOs provide high-level, culturally competent care to urban Indian populations, constituting more than 70% of all American Indians and Alaska Natives. They were authorized by Congress to fulfill the federal government's healthcare responsibility to Indians who live off reservations and are a critical part of the IHS system, commonly referred to as the ITU system. UIOs provide a wide range of services and are typically funded by a single line item in the Indian health budget. The long-standing inequity in funding caused at least 4 programs to temporarily close last spring due to the lack of PPE and resources. There have been vast improvements from a year ago with regards to availability of supply and vaccine, but that will never make up for the sheer number of Native lives lost. Unfortunately, despite improvements, the situation facing Indian country has not relented. COVID-19 is killing Native Americans at a faster rate than any other community. Due to the historical trends, we knew early on this pandemic was going to be extremely deadly for Native communities. Thousands of Native lives were lost due to systemic oppression, centuries of neglect and inaction, both before and during this pandemic. This February was the deadliest month for Natives, and January was previously the deadliest month. Moreover, with over a third of Native deaths across the country undercounted. Knowing that we do not have enough data, but the data we do have shows we are dying at the highest rates, is just blatantly unacceptable and must change now. Currently, most UIOs are offering vaccines with long lines of patients, while facilities are coordinating vaccine appointments, transportation, etc., all while at the same time still conducting most regular operations. In fact, UIOs are filling the gap that exists in the federal government as it relates to care for Native veterans. In one community, Native veterans stood in lines for hours at the VA and were ultimately turned away, refused service, and told to go to an urban Indian clinic instead. Ultimately, the UIO did not have enough vaccines to account for all Native veterans in their area. Again and again, though, UIOs are stepping up and doing more with less. The single most important problem remains the same, and that is full funding that meets the actual need for Indian healthcare. The average healthcare spending in the US is around $12,000 per person, but UIOs receive just $672 per patient, which is 6% of the national average spending. That's what our organizations have to work with to provide service to urban Indian patients. The Tribal Work Group recommendation for the IHS budget for FY22 is under $13 billion, with approximately $201 million for urban Indian health instead of the current $63 million. Our people deserve better, and this is the time to be bold and be on the right side of history. Facility-related funds remains the most requested priority for UIOs because they do not receive any, unlike the rest of the system. One UIO stated that facility funding would enable them to get back to serving the same amount of residential treatment patients as pre-pandemic days. Not only is this lack of funding detrimental to sanitation, it also drastically reduces the number of patients UIOs can see due to social distancing, further compounding health issues in Indian country. Even worse, restrictions prohibited them from making any renovations solely because they are UIOs. Thankfully, our advocates on this committee were able to assist them with loosening restrictions regarding infrastructure upgrades as it relates to COVID-19. We are working on a permanent fix, and we'll ask for your support when it's introduced. Currently, IHS is the only agency that has a requirement to consult, or in this case, confer with UIOs. An HHS urban confer policy would have been beneficial for vaccine distribution. The deadline to decide between receiving a vaccine from IHS or state jurisdictions was not clearly communicated to UIOs, with national messaging only being addressed to tribes and UIOs not mentioned, even though they're required to. Almost all UIOs felt rushed in their jurisdiction selection due to inadequate communication that could have been avoided with an urban confer policy. So we respectfully request the committee support confer policies with any agency that has jurisdiction over Indian health, including HHS, CDC, and SAMHSA, just to name a few. These requests are essential to ensure that urban Indians are properly cared for both during this crisis and in the critical times following. The trust and treaty obligation does not disappear in the midst of the pandemic. Instead, it should be strengthened as the need in Indian country is greater than ever. We urge Congress to take this obligation seriously and provide IHS with all the resources necessary to protect the lives of the entirety of the Native population, regardless of where we live. And looking at the numbers, I am lucky to be standing here right now. And as a Native woman in an urban area, I hope I'm still standing by the time we figure this out. Thank you for letting me testify today.
Thank you so much for your testimony and those sad statistics. We will now turn to our next witness, and I now recognize Mr. Larry Curley, who is the Executive Director of the National Indian Council on Aging.
Madam Chairman, thank you very much, and members of the committee, thank you very much for the opportunity to share with you some of the experiences that we have dealt with in Indian country, especially among our older Indian population. As you have heard the data, you have heard the statistics about the impact that has had in Indian country. One of the things that we are very concerned about is that of the 272,250 Indian elders and Alaska Native elders in this country today, that in this past year in Indian country, 5,981 people have died. Of that number, 60% or 3,589 people were elders. Those represent our culture, represent our traditions, our customs, our language. They will not be replaced. They cannot be replaced. And the concern that we have here is that as we look at that, the numbers of elders that have passed away, it represents 233,000 years of cultural knowledge, wisdom that are gone now. We can't ever get it back. And that is disconcerting to me. But as a national organization, we take a look at what is happening in Indian country as it relates to COVID. One of the things that we're finding now is that we are learning a new language. It's called Zoom. It's called WebEx. It's called GoToMeetings. That's our new lexicon in Indian country. But as we begin to experiment with this new technology, we're finding that that's not all available in Indian country, that internet is not accessible in some areas. The internet and the broadband is not available. And so that compounds the problems in terms of providing health care, education programs for our young people. And it is something that is going to impact Indian country for quite some time. One of the things that I want to do is just, rather than reiterate data and statistics that we have already heard, what is it that we need to do? I know that in Indian country, there are a number of tribes out there, for example, who have been concerned for over 40 years. The National Indian Council on Aging was created in 1976. I was one of the co-founders. I was a graduate student at the University of Arizona when we created this organization. We have been talking for the last 40 some years, create an assistant secretary for American Indians, Alaska Native aging within the Department of Health and Human Services. Secondly, we believe that Title 7B of the Older Americans Act needs to be fully funded. It's the law, it's there, but it has never been funded in all of the time that has been in existence. This particular pot of money and this funding source would provide funding for the establishment of elder protection programs. Three, I think one of the things that concerns me as well is that in Indian country, there are 16 nursing homes, long-term care facilities on Indian reservations across the country, with a total bed capacity of 851 beds. Statistics that have been done otherwise elsewhere have shown that at any given point in time, 5% of the elders are in nursing homes at any given time. If you apply that same percentage to Indian country, 13,000 older Indians are in nursing homes off reservation. We need protection for those elders who are off reservation. And there is a piece of law called the Indian Child Welfare Act. If it protects Indian children, Indian elders are also important to us. We need to pass legislation that would protect our older Indians who are in nursing homes off reservation. That would be a major accomplishment in terms of addressing the needs of older Indians, and especially in light of the fact that pandemic has been hitting hard in Indian country. There are statistics studies that have been done that show that 1 in 3 older Indians will suffer dementia and Alzheimer's, compared to 1 in 5 in the non-Indian community, which means that there is going to be an increasing number of older Indians who need care. There are very limited funds for caregivers in Indian country. That needs to be increased in terms of funding. And there are tribes now thinking about building nursing homes in Indian country. There are no funds available for that. I would suggest that one look back to the 1960s when there was a piece of legislation called the Hill-Burton Act, which created rural hospitals across the country. Maybe a similar piece of legislation to help tribes build nursing homes would be very helpful. And Madam Chair, members of the committee, thank you very much for the opportunity to share our thoughts and recommendations with you. Thank you.
Thank you for your testimony. I now recognize Mr. Adrian Stevens, who is the acting chairman for the Board of Directors of the National Indian Housing Council.
Good afternoon. My name is Adrian Stevens. I am the acting chair of the Board of Directors of National American Indian Housing Council. I am a member of the Seneca Nation in New York, and I currently serve as the executive director of Seneca Nation Housing Authority. I appreciate the opportunity to testify before the House Subcommittee regarding the impacts of COVID-19 on tribal housing, and I would like to thank Chairman Leger Fernandez and Ranking Member Young and committee members for having this hearing and including tribal housing issues. In addition to the comments I will make today, I have submitted a formal written statement for the record. To put it simply, there is a long-standing housing shortage across Indian country. The hearing today is meant to discuss the impact of COVID-19 on tribal communities. But for tribal housing, it is more appropriate to discuss how pre-existing housing shortages has impacted and increased COVID-19's ability to cause greater harm in our tribal communities than other parts of the country. According to a 2017 housing needs assessment in tribal communities, 1 in 6 tribal homes suffers from overcrowded conditions. That is 8 times the national average. In many tribal communities, you will find 3 generations or larger extended families living under the same roof. It is impossible for families to practice safe social distancing under these conditions. That same HUD assessment found that over 5% of tribal homes lack adequate plumbing, create unsanitary conditions, and prevent even basic safety measures like washing hands adequately. It is no surprise then that COVID-19 has disproportionately affected Native Americans at rates higher than any other demographic in the country. Tribal housing programs have scrambled to keep up with housing needs for years. Tribal housing programs have seen their purchasing power decrease by a third as funding for tribal housing has been relatively stagnant since the HASDA was enacted in 1996. For 25 years, we have asked tribes to maintain our existing housing stock and build more homes each year, all while receiving less money to do so and seeing population growth in our communities. And it's become even more critical during the pandemic to find new housing units to reduce overcrowded conditions. Tribal housing programs appreciate that Congress has provided new funds under the CARES Act and an American Rescue Plan. However, it is just not possible to build new housing units at a snap of a finger. Housing development and infrastructure they need often take months or years to plan and implement. So it has been difficult to protect our families from COVID-19 in the short term with such a housing shortage. Tribes are still finding successes. Tribes have been able to utilize COVID relief funding in a variety of ways. Some tribes have been able to turn tribal community facilities into short-term or quarantine housing. Some have been able to expand their rental assistance programs to enable families to leave overcrowded conditions and find new homes. Some tribes have been able to deliver food and supplies to families to reduce their exposure to COVID-19. But there are still gaps in providing safe and affordable housing in our communities. In some instances where there aren't any available housing units locally, tribes have had to aid families in moving 50 or 100 miles away to find a home. Recent rental assistance funds provided by Congress are limited to low-income families. Many tribes are already providing that type of assistance to our low-income members, while those just above eligibility thresholds are still struggling with paying rent and mortgages. Additionally, more flexibility and assistance to families in need, as many families may not necessarily need help with rent or mortgages, but rather increase expense of childcare or other unexpected costs due to the pandemic. So I hope there are 2 takeaways from this hearing with regards to tribal housing. First, the increase of funding to tribal housing programs has been very helpful, and tribes are stretching that funding as far as they can to help families in our communities. We want to thank every member of Congress who has been supportive of these resources. Second, and more important, Congress must address the housing shortage in Indian country and not wait for the next pandemic or a crisis to do so. Adequate housing is vital to a community's health and well-being, and the United States cannot say it is living up to its trust and treaty responsibilities when safe, affordable housing opportunities in tribal communities lags so far behind the rest of the country. Adequately funding housing development in any country has many benefits. It creates quality construction and trade jobs in communities where they are desperately needed. Building quality homes will attract and retain healthcare, education, and law enforcement professionals in our communities, when so often the lack of housing options drives professionals away. Developing enough quality homes for everyone will improve health outcomes for our community, which will create savings in healthcare and improve the educational options for our tribal youth. So let's not wait for the next crisis. With that, I will end my statement and look forward to answering any question you might have. Thank you again for highlighting the housing issues for Native American, Alaska Native, and Native Hawaiians. Yeah.
Thank you so much for your testimony here today. And now I'd like to recognize Dr. Charles Grimm, who is the Secretary for the Chickasaw Nation's Department of Health.
Thank you, Chair Leger Fernandez, Ranking Member Young, and members of the committee and subcommittee. We appreciate you holding this hearing today. The mission of the Chickasaw Nation is to enhance the overall quality of life of the Chickasaw people. In 1994, we entered into a self-governance compact to become a tribally operated healthcare system. We currently serve over 110,000 patients through a hospital and 3 outpatient facilities with a staff of over 1,600. Our nation is gripped by the most unprecedented public health crisis in generations. The statistics I've highlighted in my written testimony illustrate the lethal course of the SARS-CoV-2 virus in first Americans and are indicative of the widespread disparity in health outcomes. Chickasaw Nation Governor Bill Anatoby declared a state of emergency on March 17, 2020. Because of the swift action and declaration by Governor Anatoby to close all non-essential businesses and offices in the Chickasaw Nation, we were able to initiate COVID-19 safety policy and procedures, screening, testing, contact tracing, case investigation, epidemiologic surveillance, and environmental controls. Because of this, the Chickasaw Nation workforce of over 11,000 experienced significantly lower rates of coronavirus infection as compared to rates within our communities in the state. We were able to maintain a 7-day % positive testing rate that was 50% or less than rates seen in the community and state. Presently, our 7-day rolling average for employees is at 0.96% compared to the community rate of 10.59%. Our approach allowed us to find almost all infections outside of the workplace and allowed a data-driven approach to perfecting our mitigation processes. We tested the integrity of these processes by weekly random testing our workplaces for asymptomatic positive employees. If workplace spread became a concern, suppression testing combined with isolation, quarantine, contact tracing, and epidemiologic investigation was quickly deployed to extinguish any spread. We are very grateful that Congress and the administration recognized the great need in Indian country and that each previous COVID-19 relief package included important tribal health provisions. These funds allowed the Chickasaw Nation to operate robust testing and vaccination efforts. To date, we've performed over 106,000 tests and administered over 35,000 vaccinations to both Indian and non-Indian people alike. In our further efforts to address the pandemic, we planned and constructed several healthcare facilities to increase our capacity to care for patients, provide critical testing and training, and improve mitigation efforts. These facilities included a new alternative care site that has large, open, and easily convertible space available to plan, train, and equip as needed for COVID-19 surges. In fact, it adds 48 beds to treat COVID patients. Another project provided expansion for the hospital, which includes medical laboratory space for new COVID-19 equipment, inpatient pharmacy services, and medical supply. We also constructed an emergency operations facility, which is used to provide a COVID-19 joint operational and unified incident command, COVID-19 drive-through testing and vaccination center, and COVID-19 condition storage space for personal protective equipment and other essential equipment and supplies. The nation realized that some people have living situations that make safely isolating very challenging. So we constructed the Chickasaw Caring Cottages, which provide facilities to isolate COVID-19 patients from others, which is key to preventing community spread. The Chickasaw Nation employed various methods of ensuring our citizenry had safe and adequate nutrition. By utilizing COVID-19 funding, we issued more than 727,000 meals. As a sovereign tribal nation, we've taken great care and pride in providing support and assistance to our citizens and community members during this time of hardship and adversity. In addition to the health programs, the Chickasaw Nation established other programs to keep our citizens and employees safe and ensure they receive the support necessary to endure the health and economic hardships resulting from this unprecedented public health emergency. These other important programs are well outlined in my written testimony. We feel there are many good lessons to be learned in how the Chickasaw Nation managed this crisis and remained good stewards of the funds we were provided by Congress to prevent, prepare, and respond to this pandemic. We remain committed to ensuring the highest quality of health care for our patients, and we look forward to working with Congress as we move forward in recovering from this pandemic. Thank you.
Thank you very much. And this concludes the testimony of our witnesses today. We will now move to questioning from the members. I'm reminding the members that Committee 3D, Rule 3D imposes a 5-minute limit on questions. The chair will now recognize members for any questions they may wish to ask the witnesses. I'll start by recognizing myself for 5 minutes. As I discussed in my opening statement, today's hearing is not only about recognizing the terrible impact of COVID on Indian country, we must also identify ways in which we can address the root causes of the devastation. You know, we asked the witnesses to give us proposals to, as Dean Young said, to act. The witnesses have given us a long list of work we can do here in Congress to address the grim statistics we heard about today. I heard over and over again in today's testimony about the need for full funding. Everybody mentioned the fact that they are not receiving sufficient funds as promised and as the trust responsibility requires to carry out that work. We also heard about the lack of infrastructure such as broadband, water, and housing. I appreciate the testimony as well that the rescue plan and CARES and others, that funding, sometimes it takes time to implement, right? We cannot sprinkle water and all of a sudden have the housing we need. The other thing I heard a lot about was the need to have flexibility, whether it's in working in forestry or in housing. Mr. Stevens, in your testimony, you highlighted that 15.9% of tribal homes were overcrowded compared to 2.2 nationally. Do you think there is enough flexibility in the tribal housing funds, whether that made available by the American Rescue Plan, to address the need to address this housing crisis, and at the same time reflect that tribal housing should reflect the desires of a tribe in terms of how they want to structure their housing to reflect their culture and way of life?
Yeah, I think when we look at this, the flexibility that we really need, I think, is to be able to know we need to provide that housing for our communities. You know, the overcrowding, as I mentioned in my testimony, is really it's not well known out there that, you know, it's always been our custom, tradition, multi-family, generational, especially here at Seneca. Many, you know, may not know the history that we used to live in longhouses. And those longhouses housed 4 or 5 families. If you do that today, that spread or anything, if you have pandemic like it is now, it's going to spread that quickly. Having that separation and unit, even though having the families live in the same community, will help. So I think having that flexibility with the funding that we need to build more houses is dire to our communities and our programs to make that happen at some point. And if Congress can do that, then I think that will be able to ease some of the burden that we do have on this crisis that we're all facing. So.
And Chairman Costan, could you describe to us what kind of changes you might want Congress to implement with regards to providing the flexibility that you would need, and from whether it be in the issues as you address them?
Well, you know, first of all, I'd like to actually comment on the, you know, housing shortages, you know, that many tribes are facing. You know, it's not only just for overcrowded homes, but, you know, we have a pretty large community of homeless population on our reservation. And then, you know, including within the housing needs on a reservation to recruit working professionals, especially medical professionals, to rural communities like Washington State. It's always difficult because we don't always have the available housing for working professionals as well. So, you know, I just wanted to comment on and add to that as well. But, you know, the homeless crisis, and, you know, not only because for our own tribal members, but we have a large population of migrant workers on our reservation as well. And, you know, which has, you know, exacerbated many of the COVID issues here on our reservation. So they work in the agricultural industry, and because of, you know, these areas where a lot of them, you know, they had provided housing, but they were in very crowded conditions, many of them actually left those areas and moved onto the reservation and camped in different places. And so, which, you know, when we experienced the wildland fires, that was one of the problems that we needed to address as well. Was we had, you know, many people who were actually living out on a landscape, you know, with no communication at all. So, you know, we could probably talk about that one subject all day, but there is definitely a housing crisis on many reservations.
Yes,
I think.
So thank you so much for the testimony. I'm going to gently move us on because yes, these issues could require hours and we will spend more time on it as we work on legislation. I would now like to recognize our ranking member, Dean and Congressman Young, for questioning.
Thank you, Madam Chair. And I have a bill with Betty McCollum. I'm going to ask the panelists about advanced funding for all the programs. I'm not asking any one specific person, but anyone would like to comment. Would that solve some of our problems? Anyone?
I see heads going up. Do you want to take that one, Francis?
Oh, I think we all appreciate that. Thank you. And sorry for my coworker here. Yes, I think that, I mean, that would solve, you know, I can't speak for the tribal leaders, but I know that has been a huge issue and longstanding true funding, like, you know, advanced funding like the VA. And I think that would really help us. And especially with shutdowns, I mean, they're just really painful in our communities, and so that would save that very well. So yes, I think we're interested in that.
Well, thank you, because I think that's one of the problems we have with all our contracting and everything. How does anybody run a good program if you don't know how much funds you're going to have ahead of time? And lastly, I want to thank the witnesses. You're all very, very articulate in presenting your points of view. And Madam Chairman, I would like to suggest respectfully that you get together with the rest of the members of the committee and let's write a new American Native bill on all the issues. The housing is a big issue. The water, all, and write a bill that will address all these problems. Make it a celebrity bill, really, so that we can get something really out in front and don't get it all in one bite. At least it's out there and people start talking about it. Because right now, as I said before in the past, my 48 years, we do a lot of talking and not much action. So I would like to suggest we could do that and have a bipartisan bill addressing the indigenous people of America and the salvation and solution to problems that they're facing with funding, the whole bit, the housing, the water and sewer, education, transportation, you name it. And we can do that, I believe, when we get our heads together and do a good job. With that, Madam Chair, I'm going to yield back my time.
Thank you so much, Ranking Member and Dean Young. You are on phone, so you could not see all the smiles and nodding heads when you suggested such a historic, comprehensive Native American in Alaskan and Native Hawaiian bill. I will now recognize Chairman Grijalva for 5 minutes.
Thank you very much. Madam Chair, thank you very much. And to the ranking member, he's absolutely correct. I think we can continue to deal with issues as they come up, quality of life issues that we heard of today that are important, healthcare, accessibility, and to it, housing, water, infrastructure, the safety net programs that Indian country needs, all those things. And I think that the dean is correct. I think that looking at it in a comprehensive way, I think gives us the full picture. 3 issues, if I may, Madam Chair, that I thought were very important today, or at least to follow up. Mr. Curley, thank you very much. I think your point about looking at the kinds of guardrail protections for older indigenous folk, native folk in nursing homes off the reservation, how do you extend that protection and that oversight by tribes is, I think, a very important point, and something that I think that and building assisted living capacity on the reservation are 2 points that I think really merit a real look at. And Ms. Crevier, Francis, let me ask you about a couple of things. Another theme that came up was the issue of consultation and the government to government relationship and the trust responsibility. And you mentioned the urban confer policy that is needed. And also, I think, the consultation process that wasn't what it should have been at all, hasn't been for a long time, but certainly not around the COVID response and the role that nations and tribes had in that. Tell me a little bit, if you would, Ms. Crevier, about the urban presence of Indigenous people in this country, where the majority of the population is in some of the bigger urban centers. How do you see both the confer policy and the resource to non-tribal Indigenous folk that are off the reservation in urban areas, Oakland, LA, Phoenix, Albuquerque, and the list goes on, Chicago? How do we respond to that? How do you see us moving forward on that? And with that, I'll yield back after her response. Thank you, Madam Chair.
Thank you so much, Chairman. The IHS has a confer policy that was enacted with the Indian Healthcare Improvement Act, and that has been helpful in making sure that there's a direct connection between the agencies and the UIOs. UIOs are not tribal governments and would not act as though they are tribal governments. That's a unique relationship, but because there is a relationship to the trust obligation, we believe that there needs to be a confer policy, because for the vaccine hesitant, the HHS vaccine allocation, distribution, they sent letters, but they only sent them to tribal leaders, even though they required UIOs the same things that they required of tribal organizations. And so it's really, to me, an oversight, because they are requiring things of UIOs. They're just not talking to them at all, and they're not allowed to without authority. And so I do believe that could be fixed. And all of these tribal leaders, they have a lot to do on the reservations. They have a whole governments to run. And so we try to look out for those who live in the urban settings. And so the resources still, needs to go to them as well. And it should never be taken from tribes. It should always
at the expense of, yes.
Right. It should always be,
Separate.
Separate. Absolutely.
Yeah, a lot, Madam Chair, a lot of discussion we'll probably have because of the demand from Indian country, and also from, before you were a member of this committee and in Congress, and others throughout this, and members of Congress, the needed reform of the consultation process that has to happen at a legislative level. And I think the question about what communication, what conferring occurs in terms of native response to those agencies, I think that's something that needs to be part of that discussion as well. And with that, I yield back, Madam Chair, and thank you. Very, very good hearing. Appreciate it.
Thank you.
Thank you, Chair Grijalva. And now I'd like to recognize the ranking member, Congressman Westerman.
Thank you, Madam Chair, and again, thank you to the witnesses. My first question for Secretary Grimm, and you did a good job in your testimony of describing all the proactive steps taken by the Chickasaw Nation Department of Health throughout the pandemic. And I would like to be the first to congratulate you, as your actions have no doubt saved thousands of lives, both on and off the reservation. My question is, do you believe you would have been able to take these actions as quickly as you did if you weren't a self-governing tribe?
Thank you, Congressman Westerman. I'll first start out by answering that, saying, the decision to become a self-governance tribe or to stay what we call direct service tribes are both issues of self-determination and made, by the individual nation. However, I think the fact that we are running our own health system, we are a self-governance tribe, and we have a lot of other programs within our venue, allowed us to make decisions very rapidly for our citizens. It allowed us to open up services as soon as we felt like we could, without having to go through any other process and what we do right now, within our nation for any of the other businesses. And we were very quick. Governor Anatubby was very quick to open our services, testing, vaccination, and even as a referral source into our hospital when hospitals began to get full, for non-Indian patients. So I absolutely think that was a big plus for us.
Yeah, and you obviously were able to work effectively with both state and local governments. I think it's a good thing we can take from the pandemic, the way you all functioned with your self-run health system there. I want to switch gears a little bit, go over to Chairman Costan. And you highlighted in your testimony the need for more active forest management to reduce the threat of catastrophic wildfire. Could you describe some of the challenges that you faced during the pandemic in trying to fight wildfire and do forest management during the pandemic?
Well, I think, one of the biggest challenges that we had in this last fire season, there was catastrophic fires that were occurring throughout the Pacific Northwest and California and Oregon and Washington. And, so wildland fire resources were spread very thin, and working with both state and federal governments. Communication, I guess, is probably one of the areas that I really feel that we had a huge impact to us in looking at maintaining, that real-time communication, with our communities. With these wildland fires that we experienced, we had a lot of blackouts on our reservation and a lot of in our communities. And, so without having the internet capability or communication, there was just no other way than, at times we even had to have our staff go from house to house just to make sure that a lot of our people, especially, those of our vulnerable populations, were safe, and to give them updates on the fire. And at one point, that many of our communities were evacuated. And so communication, not only for, safety and security of our people, but for telehealth, telemedicine, and all the other purposes and needs for to have broadband access. We also have been experiencing a lot of dense smoke in our communities. And sometimes this smoke, can last for months. And again, for our vulnerable communities, our populations, coupled with COVID, that just created many problems for us as well. And then having a shortage of, the medical personnel, as well as, other safety or even wildland fire personnel. It was very difficult to recruit anybody onto this reservation, especially when they were already spread so thin in many different ways, including dealing just with the COVID virus or pandemic itself.
And with your, you're talking about smoke, and I've got a little bit of time here left. I know you've, I think, a little over 900,000 acres of forested land on the Colville Reservation. That 71% of that's in active forest management. Whereas if you look at the Forest Service, only 35% of their forest is managed. And quick question, do you think the Forest Service could learn a thing or two from the tribe about how to manage timberland?
I think that we all need to work together to manage our timberlands, because the wildland fires just don't stop at jurisdictional borders. And, so if there are unhealthy forests, in the Forest Service, which, we do have Forest Service lands adjacent to our reservation, and, it would be great to have that opportunity, for either in the Good Neighbor Authority or even with the Public Law 93-638 contracting opportunity, for us to be able to work with our local federal agencies to work with the tribes in management of many of the issues, that all of our lands experience. Unfortunately, under the Good Neighbor Authority, tribes right now cannot keep the receipts derived, from working on projects under the Good Neighbor Authority. And so that is something that needs to be fixed. Also,
Thank you, Chairman Costan. And hopefully we'll be able to receive additional response, perhaps in a written response. I would now like to recognize Congressman Soto for questions.
Thank you, Madam Chair. It's an honor to be here. We know it's been a trying time for the entire nation with this dual crisis, but particularly our tribal nations. We saw some positive news out of Florida. The Seminole Tribe of Florida has been vaccinating tribal members since late December, and now they're opened up to every tribal member 18 years or older. We know, given the history of both immunity and health services and other matters that make our tribes more vulnerable, it's really important that we are aggressively getting vaccines to our tribal nations. And we saw the feds help through the Indian Health Services with our local tribes here in Florida. And then we saw record funding under the American Rescue Plan, $31 billion to tribal nations, $20 billion for COVID response, remaining funding for public safety, housing, and other key matters. But I would recognize that under the CARES Act and subsequent to that, we saw some distribution problems that we need to make sure we're getting right and working with Treasury and others to fix. I read about the Shawnee tribe that was erroneously listed as having a 0 population when in fact they have more than 3,000 tribal members, and are currently having to sue the federal government for the 12 million they would normally be entitled to under the formula. So we know data being submitted correctly and distributing the funds continues to be an issue. Chair Lindsey, your testimony mentions the shortage of data regarding Native Hawaiian communities and how it has clouded the complete picture of their unique disparities and needs. Can you briefly elaborate on this problem and in general, how the public health crisis like COVID-19 further exacerbated this problem?
Which chair are you referring the question to, Congressman Soto?
Chair Lindsey.
Thank you for that question. I'd like to have my staff get back to you on that and put it in writing, sir.
Absolutely. And Chair Lindsey, do you have any recommendations for the federal level on how to have the federal government do better in collecting data?
I do. I think that you could probably engage with the Office of Hawaiian Affairs, as we do have a very large department putting together our data here, but we do need more help, and nationally as well as locally, so that we can help our people better.
Thanks so much. My next question is for Ms. Crevier. In general, what system inequities has COVID-19 pandemic exposed for the urban Indian organizations and their position in tribal healthcare?
Thank you for that question. So it's been a lot. If you look at the IHS budget and all the line items that there are there, you're seeing facility fund, behavioral health fund, all these other components that urbans just do not have access to. And so that has been the most tremendous challenge, especially for facilities, because obviously COVID is very infectious and you have to sanitize and you have to make it safe for your staff and safe for the patients. And in earlier packages, we were not able to use those funds at all for that. And then I think another issue is flexibility of funding, which I think has also been an issue that urbans have had, where there's funding for testing, but then in some areas you can't pay for someone to hire to test, but you can pay for the test kits. And so some of those rigid, definitions or flexibility, I think is really important. And then I did also want to touch on your data question. So CDC, the way they count data, if you're mixed, if you're Native and something else, sometimes they'll put you, if you're Native and white, Native and black, sometimes they will put you in the white or black category, or they will put you in the other category, which means we disappear. And so it is really important, I think, to work with the CDC on how we count, but also we've been working with Google and Morehouse on their HHS project, and nowhere are they, because of the way that people count anything, if it's too small of a number, they think it doesn't matter. And that's been institutionalized in our education system. And so everyone they don't realize until they're trying to find Indian data how hard that is. And so I think fixes within CDC would be a good start. Thank you.
Thank you, Ms. Crevier, and my time has expired.
Thank you. I would now recognize Congressman Rosendale.
Thank you, Madam Chair and Ranking Member, and thank you all for joining us today. As you know, I represent 8 tribes in Montana, all of which have been hit very hard by COVID-19 pandemic. Tribes often lack the adequate infrastructure for transportation, medical facilities, and telecommunications. Congress has provided an immense amount of funding during the COVID-19 pandemic, and accountability and transparency must be adhered to by the Biden administration. When Congress passed the CARES Act, it gave the Treasury Secretary discretion to determine the funding formula for tribal relief. The Treasury used population data for Indian Housing Block Grant from 2010. Unfortunately, this severely undercounted tribal members and underfunded many Montana tribes. This is why I sent a letter to Secretary Yellen recommending she use certified current tribal enrollment data to determine the funding formula for the American Rescue Plan. It remains a priority to me to ensure that Montana tribes receive the necessary resources to combat the COVID-19 pandemic. So, my first question, $30 billion was provided to Indian country through the American Rescue Plan Act. In Montana specifically, there's a need to close that digital divide. The lack of broadband access across Indian country has been a paramount issue during the pandemic. According to the FCC, tribal lands are 4.5 times more likely to lack any terrestrial broadband internet access opposed to those on non-tribal lands. Dr. Grimm, how can these funds as telehealth and tribal students are able to access the same distance learning opportunities available to other Americans?
You cut out just a little bit, Congressman, so if I don't hit this question right on, let me know. But you're right. I mean, one of the things that we already knew about and was greatly exposed during the pandemic was the lack of broadband access in Indian country. It was around telehealth and the need to use that. It was around kids who weren't able to go to school. And then we're having issues with being able to not do homework from home. And it affects businesses in tribal communities that aren't able to access it. One of the things that the Chickasaw Nation has done was to, we have a company that we decided to put a ring of broadband around our reservation area. And we're partnering with end unit companies to take it to the final destination, the homes and the schools and things like that. And we've put a lot of money into that, but we have a proposal that will help us provide both a fixed broadband as well as, the fiber broadband. So I think there are a lot of communities across the nation, Indian country, that, if given the funding and the ability, would be able to do similar projects. But again, this is not one of those projects that goes quickly either, Congressman.
It isn't. I appreciate that. So how can Congress work with the tribes to provide oversight and ensure the funds are being spent to close that digital divide to prevent waste and fraud?
I think one of the ways that I'm familiar with relative to the Indian Health Service is, when funding is given out, check with the tribes on a regular and recurring basis, to determine what they're doing with their projects. I mean, it's very similar to what IHS does when we do the joint venture construction projects. There's a very close working relationship between the cognizant agency and the tribe on significant projects like that. That's just one recommendation I'd throw out.
Okay, we're getting down to it here. So let me ask you my wrap up. Are there statutory limitations for the expansion of telehealth services that the tribe is encountering?
Absolutely, there is. One of there are a lot of them, and I'll just say that from the health perspective, CMS has a tribal technical advisory group, and we're currently in the process of working with them to develop a list of what sorts of barriers there are that are regulatory and what sorts of barriers are statutory. And I have a list of some I could mention today, but in the interest of time, I won't. But we would like to provide Congress that list when it's completed so that you'll be aware of which ones are statutory that would require congressional help.
Appreciate it. Thank you very much, Madam Chair. I'll yield back.
Thank you very much, and we look forward to receiving this list. The chair would now like to recognize Congressman Ruben Gaya.
Thank you, Madam Chair. Ms. Crevier, thank you for being here. I have a question regarding construction and construction regulations when it comes to the UIOs, and I have some great experience with working with UIOs. But I think you mentioned in your testimony that there has been some restrictions. So can you expand on that and why the current limitation of facilities funding is no longer applicable to UIOs?
Sure. Thank you for that question. So the Indian Healthcare Improvement Act, it allows for UIOs to only use funding for facilities when it is for JCAHO accreditation, which is very specific, and it is not, and most of our facilities do not use JCAHO as their accreditation. They mostly use HHC. And so that has been the biggest hangup, is that you have to be in the process of getting JCAHO accreditation to get it. And so that's not related to COVID. And so that has been the biggest problems in the earlier package, was that it was following the same guidelines. And then when we were able to talk with you all last time, it was able to get, there's some language that was tweaked for COVID specifically that would allow this funding to be used, but that's not a permanent fix. And so we are definitely looking for a permanent fix for that.
Great. And then because of the current facility restrictions, how are UIOs forced to raise money for these projects? Also, how has this limitation on funding impacted UIOs during the pandemic? I think you kind of already went into that a little.
Yeah. So you're asking how is, can you say that again?
Sure. Because of the current facility restrictions, how are UIOs forced to raise money? How do they raise money essentially? And also, how has the strict limitation on funding impacted UIOs?
Okay, so 11 of our facilities are HRSA funded facilities, and so that has been helpful for them in terms of expansion. I think some have possibly had grants from their local county or city, or have done capital fundraising campaigns or third-party billing. Some of our facilities do not have third-party billing, and solely can only use IHS funding, and so they have not been able to, and that has been one of those barriers. And so we have seen time and time again, we need negative pressure rooms, we need we need different dental machines from what we've had before because of the way that COVID, so that restriction has impacted the amount of patients we can serve. And so in places, and actually in places on the East Coast, there's no urban program that's a full ambulatory, they're only outreach and referral. So we're seeing right now our Baltimore program is trying really hard to get the vaccine, but they're not reaching referral. And so some of our people here are actually flying back to the reservation to get their vaccine, and that also puts them at risk. And so myself, I have not been vaccinated, and I keep assessing, is it worth my life to try to travel and figure out where to go? Should I stay here and wait and hope? And that's literally what a lot of urban Indians are having to figure out right now, because we don't have access. And so that's been a huge barrier.
Excellent. Thank you. Thank you, Madam Chair. I yield back.
Thank you very much. The chair would now recognize Congressman Obernolte.
Thank you, Madam Chair, and I want to thank all of our witnesses. This has been a really informative hearing. It's astonishing the degree to which our Indigenous peoples have been affected by COVID, disproportionately affected. And I think a lot of the testimony has indicated that we have larger systemic problems than just the reaction to this pandemic, that the disproportionate effects of the coronavirus are due to a systemic lack of infrastructure in our Indigenous communities. And that's something that I think this Congress is empowered to fix, and hopefully this subcommittee is empowered to fix. I am in hopes that the billions of dollars of additional funding that was passed through the American Rescue Plan are going to help us solve some of these inequities. But let me just say that I was very disappointed, and I know a lot of my colleagues feel the same way, that the Natural Resources Committee was not permitted to conduct a markup of that legislation, because I think there is a lot of institutional knowledge on this committee that could have made sure that that funding was maximized and then it went to the right place. Talking about bright spots with coronavirus in my own district, which is very rural, one of the few bright spots has been the development of telehealth and the realization that telehealth is a way of bringing rural communities together and getting them access to high quality healthcare that wouldn't otherwise be possible. But obviously that requires an investment in internet infrastructure. And so my first question is for Mr. Curley. You had specifically said that a lack of access to internet infrastructure was causing problems in your community. Can you tell us what we here in Congress can do to help with that? Is Mr. Curley still here with us?
Mr. Curley was forced to leave, and so we have asked that if there are questions for Mr. Curley, that he will respond to them in writing.
Okay, very well. So we'll certainly follow up with him. Let me go to then Secretary Grimm, because you presented one of the few success stories with building out an internet infrastructure for the Chickasaw tribe. Can you maybe give us some lessons learned and some best practices for other tribes that hope to emulate your example?
Yes, sir. One of the things that we did was we created a business around that particular sector called Trace Fiber Networks. And with that entity, we took tribal funds and any others that, might be available out there to start creating that, network of fiber around the reservation. Much like we did in the pandemic, we worked with our local communities, we worked with the state on right-of-way issues, and we worked for others to share, both the benefits of that coming into place and also get, beneficial trade-offs to make that happen. But one of the things that tribes that may not be as, successful as the Chickasaw Nation are going to need will be some additional funding that are targeted to things specifically like that. And you're right. I mean, something like this really highlighted in a number of sectors, education, as well as healthcare. So, I think taking a look at lessons learned, best practices around the country during this pandemic, like this subcommittee is doing, is absolutely the way to try to, spread some of these best practices around Indian country.
Right. Okay, well, thank you. And just a follow-on question to that, have you, now that you've built out this infrastructure, have you worked on developing telehealth, and what barriers are you seeing to getting your tribe fully engaged on that front?
So we, when the pandemic started, we were able within 2 weeks to convert almost all of our major services to telehealth. And where we run into issues, we're in some of those most rural parts of our reservation, and so we started looking at devices that might work off of just say regular telephone network, using a regular telephone to do these sorts of visits. And there are some regulatory things that, perhaps need to be dealt with. And that's one of those things that I talked about in the CMS TTAG report that we'll be, working on and giving to Congress. We'll be able to show you some of those barriers that exist to doing specifically telehealth things in those kind of areas.
Oh, great. Well, thank you. And please let us know here on the subcommittee what we can do to help you. Thank you, Madam Chair. Yield back.
Thank you. The chair would now recognize Congressman Pace.
Thank you very much, Madam Chair, and Chair Lindsey. Aloha. It's so good to see you. And special mahalo back to you for the partnership with the Office of Hawaiian Affairs on behalf of Native Hawaiians, whether at had to do recently with our amendment to the Violence Against Women Act to specify greater detail on Native Hawaiian women impacted by violence, and also to the amendment by my colleague, Kaili'i Kahele, the first Native Hawaiian to serve Hawaii in Congress in 35 years. Also the Violence Against Women Act. We appreciate that partnership with you. And to Chair Leger Fernandez, a special appreciation for structuring this first hearing of your Indigenous Peoples Subcommittee to include Native Hawaiians, because that is critical, that Native Hawaiians be recognized fully as the Indigenous Peoples of Hawaii and as one of the Indigenous Peoples of our country. I want to just reinforce a few statistics from that perspective, as this is the first meeting of our subcommittee. We have somewhere in the range of 1.3, 1.4 million Native Hawaiians living throughout our country, somewhere in the range of 20% of all Indigenous peoples of our country. We have 370,000, of course, in Hawaii, the primary location for Native Hawaiians. I myself represent 149,000 or so Native Hawaiians, second largest number of Native Hawaiians of any congressional district. My colleague, Congressman Kahele, represents over 200,000 Native Hawaiians. But Native Hawaiians are all over our country at this point. They're somewhere in the range of 300,000 plus in California, close to 100,000 in Washington state. They are integral to many of our districts across the country. Native Hawaiians for 100 years now have enjoyed a special trust relationship with our federal government, which is the same basic relationship as other Indigenous peoples have enjoyed for longer than 100 years. We have somewhere in the range of 150 federal laws that recognize Native Hawaiians in particular in the areas of health, education, small business, and beyond. We have enjoyed a very close working relationship across the country between Native Hawaiians and their brothers and sisters of the Indigenous peoples of our country, whether Native American, Alaskan Natives. And we have helped each other to advance the cause of Indigenous peoples. We've enjoyed a very close political relationship in Congress. Certainly, Mr. Young from Alaska spoke kindly to his partnership with me, but that predated me by many years with many other colleagues in the U.S. House. In the U.S. Senate, we saw Senator Danny Noe chair the Committee on Hawaiian Affairs for 10 years, Senator Dan Akaka chair the Committee on Hawaiian Affairs for 2 years, and now we have our own Senator Brian Schatz, who takes the helm of the Committee on I'm sorry, I said Hawaiian Affairs, I meant Indian Affairs, Committee on Indian Affairs, our counterpart in the Senate. And so we look forward to that partnership going forward. There is so much work to be done on a bipartisan, bicameral basis, and I look forward to that. Chair Lindsey, now that I've set that stage, a quick question for you in my time remaining. This hearing is about the impact of COVID-19 on Indigenous peoples. And specifically, as from your perspective on Native Hawaiians. And so the question that I have for you is, are there federal programs that have been of benefit to the Indigenous peoples of our country in dealing with COVID-19? Again, whether it be health, education, business, or any other category that Indigenous peoples have advantaged to help with the disproportionate effects of COVID-19 on Indigenous people, which I think we can all agree on at this point. It's a statistical fact. But where Native Hawaiians have had trouble accessing those federal programs because either they're not covered or because they are unique circumstances for Native Hawaiians. Muted.
Relatives on the continental United States, Native Hawaiian face disproportionate threats to our physical and mental health, including non-communicable diseases, poverty, suicide, and depression, infant mortality, alcohol abuse, homelessness, and prejudices against natives. Native Hawaiians are more likely to suffer from coronary heart disease, diabetes, and asthma than non-Native Hawaiians in the state. Nearly 16,000 Native Hawaiians suffer from diabetes, and more than 36,000 suffer from asthma. Now, These Hawaiians will continue to be disproportionately affected by the economic standing of the state and its major industries, because nearly 1 in 4 Native Hawaiians are employed in the service industry closely tied to tourism in Hawaii.
Chair Lindsey?
Yes.
Excuse me, Chair Lindsey. I sense my chair about to enforce the time limits as she's been so judicious in doing. So perhaps I could ask you to respond to that for the committee's benefit in writing.
We can do that.
Where are Native Hawaiians not able to access federal programs of benefit to Indigenous peoples with respect to the disproportionate impacts of COVID-19? That's the question. And I'd love to have that into our record to address it. Thank you very much, Madam Chair.
Okay, thank you.
Thank you, Congressman, and thank you, Chair Lindsey. The chair would now recognize Congressman Wadiwagan.
Talofa, and thank you, Chairwoman Fernandez and Ranking Member Young. Talofa also to Chairman Grijalva and Ranking Member Westerman for holding this hearing today, and thank you, of course, to the panel for your testimony. Chairman Costan, the end of your testimony highlights the need for increased broadband and internet access on your reservation. We see the same problems in other rural areas across the country. Besides increased funding, what needs to be done to accelerate broadband development on reservations and in other rural areas?
Well, I think first of all, that with this funding, there really needs to be a greater flexibility and recognizing that each tribe, the needs of each tribe are unique. Here at the Caldwell Reservation, we have 1.4 million acres and we have 2 mountain passes on our reservation. And so, there's a lot of issues of having, bringing broadband onto our reservation. Many providers, don't want to come onto the reservation, first of all, because there are so many challenges in really looking at understanding and working with tribal governments. And also, there are many regulatory and legal issues that need to be addressed, so many that I think that is something that we will reply in writing to. But it has been a huge impact on our reservation. And realizing, that about 90% of our reservation does not have broadband access. And so it's really, when you think about, our young people, our school-aged children, it's an unequal access to education because they just don't have the resources that many other areas do. And then too, both Berry and Okanagan counties in the state of Washington, there are high unemployment rates here, and they are 2 of the most disadvantaged counties in the state. And so, one of the discussions I remember earlier was to really even look at broadband becoming a utility. I think that could be something that could be worth considering. Many of our parents here said that even if they had broadband access, they don't know if they would be able to afford to pay for that service. And, so, there are many challenges here on our reservation. Then too, many of when you talk about telemedicine, many of our people, don't have access to broadband. And even, especially our elder populations and our vulnerable populations, getting them used to, healthcare, via the internet is something they're just not used to, even if they have access to the internet. So that and looking at right to privacy, and then also looking at what tribes can charge for, on a face-to-face versus the telemedicine, via the internet. I know that they said that earlier that we wouldn't be able to charge as much, because many of our programs are cost reimbursement, contracts with billable services. So I think that's something, that needs to be looked as a fix going far into the future. So I think really just having that greater flexibility and being able to look at, everything, all the needs across, both for IHS and for the tribes. I just wanted to mention IHS, we are direct service tribes, and, the spend down, they have to spend their funds down as well by the end of this calendar year. So that does not allow them greater flexibility as well for us to really develop programs like telehealth and telemedicine. So, those, I think, really looking at working with, FCC, the broadband mapping, there's so many inaccuracies with that as well. Even though they've got areas that they claim to cover, these large swaths of areas, in reality, most of our reservation doesn't have any coverage at all. And so, not only that, but there's a lot of different challenges that the tribes do face, especially here, for not only in the pandemic, but also, like you said, with the wildland fires and for safety and security as well. And I think even looking at, other alternative communication systems is something that needs to be addressed. So I see the time is getting near, so we do plan on providing this in writing as well. Thank you.
Thank you, Madam Chairwoman. Yield back.
Thank you. And now I would like to recognize the Vice Chair of the full committee, Congressman Garcia.
Thank you, Madam Chair, Ranking Member, and of course, all the panelists for being with us today. COVID-19, as we see, has torn through Indigenous communities across the country, leaving permanent scars. American Indians and Alaska Natives are dying at almost twice the rate of white Americans, and with some states inaccurately reporting COVID-19 cases and deaths by race, these numbers may be higher. People are losing loved ones, elders, language, and culture. This is a health, economic, and cultural crisis all in one. And yet, these devastating statistics, tribes have led many of the most successful COVID-19 vaccination campaigns in the country. Question for Honorable William Smith. Mr. Smith, thank you for your testimony. Tribal nations have received and administered COVID-19 vaccination allocations at higher rates than many other states. How has the National Indian Health Board interpreted this success?
Thank you for that question. Question was, given the experience, the National Health Board, Alaska Area Representative challenge for Alaska Natives? Or could you repeat the question, please?
Yeah, how have the vaccination allocations, how have you had the higher rates than many other states, the success rate? How do you explain that?
Yeah, over 80% of Alaska communities over vast miles, but we also have self-governments and the flexibility to be able to vaccinate. Alaska was the first state to be able to vaccinate 16 and older. And there was a little confusion in the beginning when they were doing the elders. As multi-generations in the household, I, for one, took the vaccine, but I had younger people living in my house and they should have got it, but they didn't. But they corrected that in our little community. But being have the flexibility to vaccinate by self-governance, to vaccinate all the people, native and non-native in the communities, has really helped to stop the spread of the COVID.
And did the IHS's centralized system impact the vaccine rollout in a positive way?
Yes, my Indian Health Service being able to get the vaccines to the communities, to the hubs, and then we were able to fly it out to all our smaller communities in Alaska has really been a big improvement.
Thank you, sir. A question for Ms. Francis Crevier. Just 2 weeks ago, we passed the American Rescue Plan to provide much needed relief to families across the country. The bill included $6.09 billion for Indian Health Service. Ms. Crevier, in your statement, you note that the urban Indian organizations are a critical part of the Indian Health Service, yet there's a longstanding inequity in funding and lack of prioritizing UIO needs. In fact, less than 1% of the total IHS annual budget goes to IUOs. How has this inequity in funding impacted IUOs during the pandemic?
Thank you for that question. So in the latest bill, the six, I believe 6 billion that they received, urbans are going to receive 84 million. And so the budget comes from the basic need, all the basic needs that a healthcare facility needs, and so not being in those other components. I mean, it's absolutely just astonishing. When our facilities were talking to their area offices and asking them, can we get our negative pressure rooms? Well, can we change the HVAC? They said you can only use it if it's COVID-19, and you have to, so an HVAC would not be considered COVID-19, even though, there's cleansing and all these other things. And so, I mean, the longstanding inequities, and when I say inequities, I mean inequities for Indian country, not just UIOs, really exacerbate this issue, and that's why, we are seeing the disparities we are today.
So how can Congress help address these barriers?
Full funding. Full funding, I think, is a great start. The percentage that we get of the national spending when it comes to urbans is 6%, and tribes get about 33%. And so, if you're thinking about your salary and you only get 6% of your salary, how are you going to function? How are you going to be able to do all the things you need to do as an adult and do your job? So that's kind of the challenge we're having with the facilities. Thank you.
Thank you. Madam Chair, I just want to point out that urban Indian populations continue to have among the highest COVID rates. The chronic underfunding is a real problem. And with poor technological infrastructure, we have got to address these issues. Thank you very much to all the panelists. I yield back, Madam Chair.
Thank you, Vice Chair. And the chair would now like to recognize Congressman Cliff Bentz. Congressman Bentz, are you on with us?
I am, Madam Chair. Thank you so much for this opportunity, and thanks to all of our witnesses. Just a couple of questions to Ms. Crevier. We've talked around the issue of vaccination, but I've not heard anything about how well vaccination or the opportunity to be vaccinated is being accepted. Are tribal members happy with the opportunity? Are some people reluctant? Where are we?
Yeah, thank you. That's a great question. So, in terms of the Urban Indian Health Institute conducted a study, and 75%, almost 75% of American Indians, Alaska Natives, do not have vaccine hesitancy, and it's actually due to our community, due to our relations to our community, and so we want to be safe for our community, for our family. And so we found that most people are very happy to get the vaccine and are lining up. And, to the extent that, there are, in some places, there have been cities where they have not received as much vaccine and they want to start sending, their own patients to our UIOs. But that doesn't always happen. And obviously that's not every location. But yeah, we do find that most people do want to be vaccinated in our community.
And a follow-up, I didn't ever quite understand if there is a delay in getting the vaccines to tribal members or not. Is it progressing the way you like it to be progressing, or are we falling short?
That's a great question. So I think every area is different. So you would have to talk to all these folks here about how their rollout has been. But I would say that for us, for the most part, it's been okay. In some areas, there's some, and in some areas there's none. And so, for instance, we've been trying to get the Baltimore program, and the Boston program, and the New York program vaccines since December, but we have not been able to. And so there's definitely a need for more vaccine and more allocations to UIOs. Again, not taken away from tribes, but just more. And so I think that would definitely help. But yeah, in some areas, UIOs have been very impressed with IHS and their area office and their states, and some it doesn't work out as well.
Thank you for that. Let's shift to Secretary Grimm for just a moment. So my understanding is the rescue plan had in it some 31 billion, for tribes, and the issue, of course, is as to a significant portion of it, I want to say 19 billion, how it's going to be divided among tribes. And it sounded as though the formula was being debated by Treasury and perhaps otherwise in other places. Could you weigh in and share with us how you think that money should be divided among our 574 tribes?
Congressman Benz, I'm going to submit that one to the record for you. That one is a hot one, and that one's over my pay grade, I'm afraid.
Well, I'm happy to ask anyone else that any of the other witnesses if they want to weigh in. I'd love to hear I'd love to hear something in that regard. I've read a bunch of the formulas. I find them interesting, and if no one wants to step up, I'm perfectly okay with that. But if somebody does, please speak. Not surprisingly. Thank you so much, all of you. I yield back.
Thank you very much, Congressman Benz. I'd like to once again thank our witnesses for their insightful testimony and the members for the questions. Really, this hearing was all that I would have hoped it to be. You couldn't tell who was a Republican and Democrat for the most part in the questions, because all you heard was committee members focused on what's the problem and what can we do to help solve it so that we do not have this continued devastation in our Indigenous communities. You know, and I will, and I believe we all will, take up our ranking member Young's call to have the subcommittee draft historic legislation to address this comprehensively. You know, it's our fulfilling the trust, right? We must fulfill the trust obligation. And so I will end my closing comments with that. But as I stated before, the members of the committee may have additional questions for the witnesses. Several came up, and we will be asking the witnesses to respond to those in writing, and we'll share them with the committees when they come in, with the committee members when they come in. Under Committee Rule 3.0, members of the committee must submit witness questions within 3 business days following the hearing. And the hearing record will be open for 10 business days for these responses. If there is no further business, without objection, the subcommittee stands adjourned.